resume recording. Exam 2 review. Ensure that you have your ID. The exams are available for download at least 1 hour prior to the exam time. So ensure that you've downloaded that exam before you get to the classroom. You have that hour leeway, because what that does, in the event that there's issues, you've worked that out. And you won't have that unneeded stress when you get into the classroom trying to download. Make sure you have your two devices, your chargers. You just never know when those devices the charge will run down on you. Make sure you have those. The other thing is, if you are going to have that exam proctored, you will need to send an email that includes whomever the proctor is, an approved proctor. That person has to be approved by your campus dean. So the approved proctor, your campus dean, Dean Brown, and whomever your professor is. And then our course lead is Dr. Mary. So you should have Dr. Brown, Dr. Mary, whomever your professor is, your campus dean, and whomever that that approved proctor is going to be. Remember that 72-hour notice. In the event that you have accommodations, make sure that you have shared that with the professor. So for exam 2, we are looking at content from the last 2 classes. So let me go to the modules, and so you're just looking at 2 weeks of content. Well, it seems like it's not that much. And it solely is on communication, collaboration, leadership, delegation. Those are, there's a few concepts, but there's several moving parts that make up that all those concepts. So you have week 4 material, which looks at those that are on the healthcare team. Your respiratory therapist, your speech therapist, your dietitian. We're that nurse. We're right in the middle. So all those that are on the healthcare team. We're looking at communication, being assertive, being honest, without violating other rights, versus being aggressive and non-assertive. Okay. Communication with everyone on that healthcare team, communication with the families, the doctors, and of course the patient. And then for week 5, we looked at those on the healthcare team again. And also we looked at collaboration, looked a little bit more deep, did a deep dive into that, and then delegation and leadership. So those are the main concepts that will be on the exam. So let me go ahead and share my screen here, and we will get started. In addition to reviewing the exam reviews, those links are being provided in your announcement section of your course. Ensure that you also go back through your classroom recordings, because even though we're all saying the same thing, we're talking about the same concepts, the more that you go over those concepts, you will identify if that's a concept that you need to look to do a deeper dive into, and then you'll remember, and you'll have that strong foundation about that concept. So go through your classroom recordings, the exam review links that we're being provided for you, week 3 and week 4 and 5. Week 4 and 5, there's only 2 weeks. All right, let me share my screen here. Show. Slide. So as we talk about communication, delegation, talking about collaboration with those on the healthcare team, remember, we're doing all this for that patient. We have to consider everything for that one patient. Safety, 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 safety. So while we want to keep the nurse and the healthcare team safe, by us keeping in mind safety first for that patient, that'll keep us safe as well. So client safety is priority. When we're coming up with those care plans, when we're implementing, when we're doing our head-to-toe assessments, we want to think about the client safety. Communication involves active listening. Remember that it is a sender and a receiver. So we want to ensure that the information that was sent by the patient, and also vice versa, that the information is being communicated correctly, because sometimes there is a miscommunication in the messages are being sent. So we want to make sure that we're using those active listening techniques. And we do have a slide on those here. Okay. Restating, clarifying, reflecting, paraphrasing. And then this one we kind of struggle with because we have the answers and we want to do everything for that patient. Remaining silent. That is therapeutic. That is active listening. This right here allows us to be able to gather all the information, and it lessens the chance of misinterpretation of what is being communicated. So we'll go back. Okay, key factors in active listening: purpose, the health related reason for gathering data or giving information. Got that sender and receiver. Do not assume accuracy of information without checking it out. While we will still document that verbal and nonverbal information that we have, we're going to verify it. But we do want to make sure we're capturing all of that in our documentation. We do want to clarify what you think you understand the client is saying and ask further questions as needed. A common mistake in listening is to listen to the words, but not really hear the words, comprehend and understand the message that is being conveyed. That's going back to what I just said, the sender and receiver. Sometimes there's a mix up in that information that's being communicated. So we want to use these techniques to verify, to ensure what is being communicated is correct. Using iMessages, that is very important when we are trying to establish those therapeutic relationships with our patients, because that is less aggressive, is seen as assertive rather than aggressive. iMessages, it takes down the guard on the other person that you're talking to, because you're talking about you when you're saying I. So remember, using those iMessages are therapeutic. We want to keep our promises. If we're saying we'll be back in a few minutes or on the hour at 10 o'clock or whatever that is, we want to make sure that we are, doing what we said that we can do, that we said that we were going to do. And in the event that we cannot make it back, and that's just an example that I'm using, we want to convey that to the patient. Hey, I know I communicated or said that I would do whatever at whatever time, come back and do your dressing change in 30 minutes. If something has come up, I'm going to still be within my time frame, but it won't be at that time that I communicated. We want to be aware of our body language. Make sure making eye contact, but not that it's glaring, not that we're frowning. We have facial grimacing if we're doing dressing changes. In the event that we know that there's going to be an odor, we want to see what we can do for the environment so that it is less offensive to the patient, because if you smell it, the patient smell it as well. So we want to be aware of our body language. So negative communication, the one that we kind of, we pretty much understand these, but giving advice, because you have established that therapeutic relationship with your patient, they trust you, good, bad, and ugly. And they will often ask you, well, what would you do, nurse? And so while we want the best for our patients, we have to be careful. We want them to make an informed decision, and we're going to support them in that decision, whatever it is that they make, but we want them to make an informed decision. So when they ask us, well, what would you do, nurse? Remember, we give it back to them. Is there something more information that you need? Was there something that you think you need clarification on? Do you think you need to talk to the dietitian again, the health provider again? Because we're going to support you in whatever decision that you make. So the rest of them, judging, generalized answers, everything is going to be okay, everything's going to be all right. We don't do that. That's false reassurance. But we pretty much, the only one that we kind of struggle with is giving advice. Okay. The Institutes of Medicine have created this tool, the S bar, so that we can communicate effectively, so that we don't leave out information, so that we give those important points when we are communicating, either with the healthcare provider or if we're handing off. So S bar, the tool has been used. Okay. I'm gonna let you just look at this slide for just a moment. Right. So, situation, what is the reason that we are calling or communicating? Of course, we want to tell them who we are as well. And then background, give a little background. When did the patient come in? Why did they come in? Their vital signs. We want to give them the most up-to-date vital signs, the medications, allergies, because we don't want them to, in the event that there's going to be a medication prescribed, we don't want them to prescribe something that the client is allergic to. So we want to give their allergies, their cold status, and let's say medications, allergies, yes. And then assessment. What do you think is going on based on the data findings? You've done your head-to-toe assessment. You gathered that subjective and objective data. And so what do you think? Blood pressure was administered. So the situation, I'm going to give an example, was antihypertensive was administered at 8 a.m. It is now noon. The blood pressure is higher than, it's abnormally high or abnormally low. So what do you think is going on? The patient was compliant with the medication. This client might need a change, because when you look back, and you can also go back to this background, that situation that I just gave, we can look back at the previous blood pressure measurements and see if there's a trend. Is this blood pressure staying consistently high or staying consistently low? And so that will help us to give more data, and so that recommendations or new orders are actually given. Okay. And this one is when we're doing the change of shift. It's pretty much the same thing, but we're just handing off. You're going home, and the next person is coming on to take care of the client. So it's ongoing. It's ongoing. It doesn't, the client's care does not stop. So whatever things that need to be done, we just received lab results. Lab just called in critical lab results for the client. And we have, noted that. We have attempted to contact the healthcare provider. We give them like that certain time frame, maybe 5 minutes or 10 minutes, and they haven't responded yet. We don't just leave that information there. We want to pass it on to the next nurse. Says, hey, give them the information. We got the critical lab results. We've notified the physician. We got about 5 more minutes until it's time to take the next step. So don't just leave that information hanging out there. Okay. So conflict resolution. Conflict is a natural part of life. And so this is, if the conflict cannot be resolved, the ethics committee is going to be the resource that is used to resolve conflict. So when you decide to go work at your facilities, this is a committee that you can ask to work on. All of them have them. They usually don't really talk about it during onboarding, but the ethics committee, this is the appropriate resource when other conflict resolution attempts have been unsuccessful. So, because it's, like I said, it's just a natural part of life. It could be, something as the client misunderstood, the family misunderstood what the facility's policies and procedures were. It could be the example that I gave earlier. You told the nurse told the patient that they're going to do the dressing change in 30 minutes, and they didn't come back. It was 40 minutes when they came back. So the client is saying whatever the patient is, that the nurse is, lied to them. So you just never know. But conflict is a natural part of life. But we do have that ethics committee to help resolve unsuccessful attempts for that conflict to be resolved. Let me see, is there anything else I want to say about conflict? Okay, nope. All right, so communication in the workplace. We have this DISC script, and we need to know what each letter stands for. So describe, express, specify, and then the consequences can be used for lack of coordination and follow up with coworkers. So just know the order, describe whatever is going on, then how we're going to present it, express, and then specify, and then the consequences. And it's used to when there's lack of coordination and follow up with the coworkers. Usually, when we're going to talk about the different leadership styles, you usually see this when laissez-faire is being used. When we're just when the situation is they're just letting people just make random decisions and they're not sticking to the policies and procedures. But this script, describe, express, specifying consequences does assist with resolving the issue. Okay, so chain of command. So we do have our chain of command and we do follow it. The only time that we stray away from the chain of command is in the event that there is a need for an immediate resolution or action. That's the only time we stray away from it. For example, the client is, we walk in the room, or unlicensed personnel, someone walks in the room and they observe the client has slumped over. There's immediate change in mental status. There is no pulse, no respiration. This client's a full cold. The blood pressure, we went in the room checking the blood pressure, and the blood pressure is extremely high or extremely low. We need an immediate response from the healthcare provider, because remember, we need those orders to move forward with providing care. So that in that situation, that's an emergency situation, we would notify the healthcare provider because we need an immediate response from someone that can give us what our next steps are. But otherwise, we follow the chain of command. So going back to the example that I gave earlier, where it's change of shift, and it could not be even change of shift. We've got that phone call from radiology. And usually when they call or they communicate directly to us, there is something urgent. There is some abnormality. For example, it could be a broken arm, broken hip, pneumonia. There's something. There's an elevated white count. There's not just they don't just call and contact you directly if there is a not a result that is not abnormal. So they're calling, and we'll just say the white count is elevated. So we have attempted to notify or contact the healthcare provider. The facilities policy says that, we allow the 5 minutes. We just say 5 minutes. So it's been 5 minutes. We reached back out and made that call again. Some facilities you call directly to the healthcare provider. Some facilities you still pay. Some facilities you call an answering service. But whatever that method of contact was, we followed those steps. We followed that policy and procedure. Okay. We still are not getting a response from that healthcare provider. So while this is not an emergency situation where this client has something going on with airway, breathing, and circulation, but these are results that we need to contact this healthcare provider. What do? We use our chain of command. We go to our charge nurse, our supervisor, our manager, who, some facilities might not have all of these people that are on this triangle, but nevertheless, we go to whoever's in charge and we let them know we have followed the policy and procedure. We have attempted to contact this healthcare provider about these abnormal results. We have not received a response, because there's always someone on call or it should always be someone to contact for that healthcare provider. Even if they're out of town on vacation or something's come up, they always have someone to cover. So it's never okay that we cannot contact a healthcare provider for a patient. So in that situation, it wasn't airway, breathing, and circulation, but it was something that we needed to notify the healthcare provider about. We're not getting a response. We notify our next in chain of command, whether or not it is the supervisor, the manager, so that they can address the issue. Okay. But, and like I said, unless it's airway, breathing, and circulation, we bypass that chain of command and we notify that healthcare provider, because we would need those immediate response or immediate reaction. Are we clear on how the chain of command works? If it's not airway, breathing, and circulation, then we follow our chain of command as it is. But there is instance where there's an emergency when we need a response from someone directly. I'm going to stop right here. And I think I got a question in the chat. Just make sure. Okay, we're saying yes. Okay, got it. Let's go back. Okay. All right, let's go to our next one. Okay, so I want to spend some time with this aggressive, assertive, and non-assertive. So assertive, assertive and aggressive, they're directly opposites of each other. So assertive uses statements of facts, not judgments of facts. We don't say appears. There appears that they were mad. We use those descriptive terms. Voice was raised. They had glaring eyes. Patient had facial grimacing. They were crying. We want to use statements of facts and not judgments. Even if the unlicensed personnel ask, what, even though the care plans and everything is available to them, they come and ask, well, hey, when are we supposed to, this person needs assistance. What are we supposed to do? So an example would be an assertive statement. We need to turn and reposition this client at least every 2 hours at every even hour, 8 a.m., 10 a.m., noon, and so forth. The wound care nurse might ask a question about dressing change. An assertive statement would be, this client dressing change needs to be done every shift or once a day at 10 a.m. So assertive, we're using statements of facts, not judgments, and it stands up for the rights without violating the rights of others. Okay? Without violating the rights of others. So assertive, we're taking that positive stand and being confident in our statement because we're being honest. We're not going to violate policies and procedures. We're going to speak openly to not violate others' rights. So think about privacy. You want to maintain privacy when we're talking to our patients or others on the healthcare teams. We do want to maintain that eye contact, not sustained or glaring eyes, but make that eye contact. We want to face the person. So because we do want to appear, honest, open, and then assertive communication is we talked about positive communication earlier. So assertive communication uses those I statements to express one's thoughts, feelings, or needs, and to clarify, to communicate clearly and directly. So this approach, being assertive, it allows for that honest expression without blaming others when we use those I statements or attacking someone. And this in itself, it promotes that therapeutic relationship. Okay, so let me go back over assertive here because assertive, like I said, communication is a small thing, but it's huge when you go to look at it. So assertive communication involves expressing ideas and opinions openly. We want to be respectful. We want to propose a discussion, being open to that discussion and showing confidence in one's ideas while remaining open to the input from the team, the input from the patient. Because we want it, because it does go back to, think about the client, the patient is the one that's receiving this care. So what do they value? So we want to be open and honest. We want to use those statements of facts. The examples that I gave, vital signs need to be taken daily. We're going to do them on day shift before lunch at noon or before lunch at 10. Measurement, we need to measure that blood pressure, once a shift, at the beginning of the shift, within that first hour. Those are just some examples. While I noticed that when you rated your pain on a scale of 0 to 10, you said 0. But I'm observing you're having facial grimacing, you're guarding. So that's statements of facts so that you can verify. Remember, we want to maintain privacy. Okay, so what would the nurse do? I think some examples that I gave about we're receiving those critical ads. I already gave you those examples. So what if the patient had a discussion with the dietitian and they agreed upon whatever they agreed upon? We'll just say that the dietitian talked to the patient and they were trying to decide on the alternate food items. So they agreed upon whatever the decision was. And so now the patient is coming back saying, "Ooh, I just said whatever to get them on out of here." So, but they're telling you, the nurse, because they really trust you. You've established that therapeutic relationship. So think about being assertive and being honest. So once that client gets that meal tray, they just stop. They don't eat those items. And so it's not that the client is refusing to eat or doesn't have an appetite. They just have not established that therapeutic relationship with that dietitian. So what should that nurse do? We're being assertive. We're maintaining privacy when we're talking to the patient. We say, "Hey, I know as a dietitian was in here earlier, talked to you, and I think you all I think you all came to a conclusion on the food items. I noticed that you still didn't eat. The client said, "Oh, I just said whatever to get them on out of here." So what should the nurse do? We want to notify that dietitian that this client, said what they said. Hey, so that dietitian can come back and reassess and establish that therapeutic relationship. The nurse might have to be in there. So, but we want to let that person know, the healthcare provider. Another example is they signed off on a consent. Oh yeah, they were gonna get the procedure done. I just said whatever. I didn't know what that doctor was talking about. I just went on and signed it. So we want to let that healthcare provider know, hey, this client, we're being assertive, we're being honest, we're maintaining privacy, we're not using judgment, we're stating facts. That healthcare provider know that this client just made a decision because they wanted to just get you on out. And so letting you know, because more than likely you need to come back in, and because really that client really hadn't made an informed decision to give him consent. Okay, so I think I've kind of went over assertive. Let me just give this one more time. Assertive communication needs to follow the chain of command unless it is airway breathing and circulations. And no, we gave examples earlier where we direct our information to someone that can give an immediate response. We want to maintain client safety and be that advocate for that client. So assertive involves expressing ideas and opinions openly and being respectful. All right. Now let's go to aggressive. So aggressive is all of those things that assertive is not. It involves expressing ideas and opinions while violating privacy and being disrespectful and rude. So it's completely the opposite of assertive. And then passive is where, we just kind of let's go back to the example where we're in shift change. We're using SBAR, and we know that healthcare provider hasn't called us back yet. And we know that the healthcare provider has at least 5 more minutes based on this facility policy to call us back. But we're at shift change and we don't let the oncoming nurse know. So we just kind of document it, and the nurses know. We don't let them know that, hey, if this doctor doesn't call us back in 5 minutes, because that's the time frame that they will need to follow up. That's being passive. And that's another way of being dishonest. So as a nurse, we want to use assertive. We want to use statements of facts, not judgment. Some examples were turn it and reposition every 2 hours at 8 a.m. and 10 a.m., complete the dressing change every shift, and so forth. All right, I think we got that. All right, so who's on this healthcare team? We work together to meet common objectives, and that is to provide this best care to this client to get them back to their optimal level of health. So we work together to meet that common objective. And this includes care coordination. We're going to need that, and we're going to need collaboration. So remember, care coordination is recognized as a professional standard and is essential so that we can ensure that this client gets all the care that they need. And an example that I always give is the client needs physical therapy and they also have a doctor's appointment outside of the facility. So we know that therapy usually comes at 10 a.m., but the client's appointment outside of the facility is also at 10 a.m. We're going to have to coordinate care and collaborate with both of them, either to get that appointment changed or see if therapy can come see that client at a different time. Because we don't want it to be that the client misses their appointment. We don't want them to miss therapy either. So it's going to take that collaboration. Care coordination is fundamental in improving the quality of care of delivery while decreasing inappropriate use of healthcare. So if we write it down, if therapy comes in, the client's gone to their doctor's appointment, therapy is going to say, hey, they missed their session. So that's a session of therapy that client is not going to get. So the quality of healthcare has declined because that client did not get what they need. Care coordination organizes care. Well, when we just said, change the appointment or can therapy come at a different time. Organizes the care and information about the patient's needs and preferences. Another example, if therapies come in before lunch and the clients get antsy, they're not really wanting therapy at that time because they think they're going to miss lunch or whatever the situation is. We want to let therapy know that client's preferences. And so that therapy can always more than likely schedule a different time to come to see that client. Okay. We want to promote positive client outcomes and patient satisfaction. All those examples I gave goes back to promoting that positive client outcomes. The client gets their therapy, they get their meal, they actually go see their healthcare provider that's outside of the facility. And all of that equals that patient satisfaction. It goes back to that therapeutic relationship so that that patient is going to be open to you to tell you, what their preferences are. All right. So even though we are right there in the middle, we have all these other people on the healthcare team. So let me just say healthcare workers of the same discipline that work together to integrate care that will provide clients with all the services they need to maintain that safety and that quality, comprehensive healthcare. So one patient can need all of these healthcare providers and even more. We have to be able to coordinate it and collaborate so that the client gets everything that they need. So let's see here. The dietitian, all things dietary. So think about the the meals, the food items, if they're needing a certain amount of calories, if they're needing a special diet. The client just had a dental procedure and they're needing their food soft. They can't have straws, anything dietary, anything nutrition. So we have let's see, the speech therapist, all things speech and swallowing related. They're going to be the ones that do those swallowing tests and determine whether or not this client is going to need thickened liquids, if that food needs to be altered, for example, pureed or in some different consistency. Physical therapy, mobility, getting that occupational therapy, getting that patient back to their normal, as closest to their normal, if not back to their normal. Being able to take care of themselves so that think about activities of daily living. Can this client bathe themselves? Can they feed themselves? So they'll come in and work with them on those different activities. The surgeon, what about the surgeon? They do surgery. And they're usually the ones that's going to be prescribing that pain medication. Because usually clients wake up and then those nerves start back to come alive. They're going to be in some discomfort. So in addition to that surgery that they done, they're going to also be the ones that prescribe the pain medication. I think that's pretty much it there. Okay. So let's look at this continuity of care, you all. So we want the care to continue. Just think about that word, continuity, continue. Effective continuity of care. If care continues, think about it. If we step back and look at everyone's on the healthcare team, we've looked at all the resources that this client's going to need, medical equipment, they may need meals, what they may need home help. Think about that, discharge instructions, medication management. If this client understood how to take the medicine, they had the correct medical equipment they need. If they understood their disease process and how to manage it, most likely that person will not be readmitted for that condition. So effective continuity of care, it significantly decreases or reduces hospital readmissions. Because what continuity of care, it ensures proper follow-up. This client knows that they need to follow back up with their doctor in 4 weeks, 6 weeks. Medication management, it ensures proper medication. The client understands, I need to take this medicine at night. I need to take this medicine in the morning before I eat my meals. And coordination between care providers. Patients are more likely to maintain their health and avoid complications that can lead to hospitalizations. So that continuity of care, that collaboration, and that effective communication is going to be is key. Like I said, we only have a few concepts, but they're big pieces. So if communication is ineffective, this client's safety is at risk, and then more than likely it's going to lead to those sentinel events. So remember, sentinel events are things that, for example, a patient comes in for surgery, gallbladder surgery, and they end up with surgery down on their hip. This client comes in for an amputation of left leg and the right arm ends up getting amputated because there is ineffective communication between within the healthcare team. All right, so we use these different approaches here. I'm going to read each one of these. So total patient care. You usually see this in the ICU. So no matter if this patient needs to be fed, bathed, medications, that nurse provides all that care, total, everything this person needs. So functional nursing is according to the task. A thing that comes to mind here is, for example, if you're that wound nurse in that facility, so you go in and provide wound care for all of those clients that have wounds. Team nursing, the assignments according to the capabilities. So each person that's on the team will be specifically assigned tasks to do. Meanwhile, all the care that those clients are going to need will be addressed because each person on the team will have a task to complete. And then primary nursing, 24-hour accountability, care or case management, care coordination within a specified time frame using clinical pathways. Okay. All right. Client-centered, relationship-centered care philosophy. So providing care that is respectful of, we talked about that, and responsive to the individual client preferences, needs, and values, and ensuring that client values guide all clinical decisions. So we want to establish those therapeutic relationships, see what the client's preferences are, see what they know about what they need, see what they value, what are their goals. And then we want to incorporate all of that in there. So another a theorist that comes to mind is Virginia Henderson. Remember, Henderson, her thing is she's looking at illness and wellness. So Virginia Henderson is a nursing theorist, and she stated that the unique function of the nurse is to assist the individual, whether or not they're sick or well, illness, they're ill or they're well, in the performance of those activities that contributes to their recovery. So we want to include the client preferences, identify what this client needs. They need 2-person's assistance, 3-person's assistance. Does this client have a preference not to eat milk products, pork, whatever it is? We want to include that in there so that we can have everything done that will contribute to this client's recovery. Okay. So this slide right here just shows that we looking at the client needs, pretty much everything we just said. We're using critical thinking to guide our clinical decisions. And this just breaks it down. We look at those recognized cues. We're looking at verbal and nonverbal. And we're analyzing. We're looking at a hypothesis. Is this client, did they really understand what I said when I asked them to rate their pain on a scale of 0 to 10? Because sometimes that's a lot of information for a client. And so when we're looking at them, we're like, okay, the client said 0, but I'm seeing them with facial grimacing, things like that. So do we need to reword, or do we need to use a different explanation for the client to identify whether or not they're in pain? So we generate solutions, we implement, and then we evaluate what we did. Did it do any good? Okay. Let me go back to the people on the healthcare team. The LPN, remember, we can be charge nurses at long-term care facilities. We will consult with the registered nurse. We assist with the decision makers, and we coordinate that care for that client. And then we assign and supervise unlicensed personnel. Okay, developing this clinical judgment and this critical thinking, it comes from recognizing patterns, applying concepts. So think about if we're doing an assessment and the pain, we'll go back to that example. The client is saying that they're not in pain, but then we recognize that this client is facial grimacing, they're guarding, their stomach or whatever part that may be hurting them. But they're telling us they're not in any pain. So going back to what we know about discomfort, we can go back and we revisit that conversation. We restate. Think about those positive communication techniques. We restate, we clarify, we validate information. Okay. So the QSIN, the quality and safety education for nurses initiative anticipates that collaboration will have a major impact on positive patient outcomes. Remember, the example that I just gave, or we just talked about, it lessens the chance of the client being readmitted. It lessens that client not being able to manage their medication. So we want to make sure that we're collaborating with each member on the healthcare team, because all of us are just as valuable as the next. And so we want to ensure that while we're providing patient care, that we're including the client preferences, their needs, and their values. This is just another way of looking at that collaboration. So remember that we're getting ready to talk about leadership here. So transformational leadership empowers others to set visions. So not only are we providing that best care for our clients, we're also always thinking, well, can this be done differently? Can we lessen the time? Can we use less resources? In another example of transformational leadership, when we're empowering others, we see that this nurse is, pretty good with communication and identifying ways to resolve conflict. We recommend that nurse becomes part of that ethics committee. So there's growth within that team member. So transformational leadership empowers others, and then it helps them set visions, and that person actually grows within their role while they are actually there in that facility. So we have transactional, transformational, contingency, or situation. Situation, what is that situation? It's going to vary, depends on what is going on. But transformational empowers, and that person actually grows. So we do want to empower staff to participate in improving patient care. So it's not that spirit of inquiry where we're empowering staff to provide examples, or if an idea comes up, we'll share that idea. If we can lessen, time for staff, if we can lessen use of resources, and this client's going to have better outcomes, share that information, empower staff to participate in discussing ideas that will improve the patient care and creating work environments that foster professional principles. Now, we don't want to go outside of our scope of practice, though, but we do want to empower staff to do that. All right, so let's go to these rights of delegation. Delegation is going to be a huge thing. So let's talk about delegation here. So these are the rights of delegation. So what is delegation? We're transferring responsibility for the performance of an activity from one person to the other. Okay. Even though we as a nurse is doing that, it does not mean that we are not responsible for ensuring that the outcome, or that task that we're delegating isn't going to be completed. So even though we are delegating it to another person, it does not alleviate the nurse's responsibility of making sure that task is completed. So delegation is not a required act. So in some states, you don't even use it, but we do need to know about it because most states do. So, but it's not required. So the nurse is responsible for supervising the patient care to ensure that it is completely delivered, even if a task is delegated. So when delegating tasks, the nurse must think about the skills and the competency. Let me see if this is on another slide. Okay. You want to think about the skills and the competency of the team member that we're delegating it to. So if most facilities have like a skills check sheet or a task that this person can complete. So before we delegate, think about it. Is this a skill or a task that this person, the unlicensed personnel or the CNA, is this something that's on their skill list that say that they can actually do? Have they been checked off on it that says they can do this task in this facility? Okay. Then we want to think about the condition of the patient. Is this client stable or unstable? Because even if it's a task that is on the unlicensed personnel or the CNA's task list, they can complete in that facility, and that patient is unstable, we would not delegate that task to that client, to that unlicensed personnel. So let me just give you an example. Okay, so a bath, denture care, mouth care, measuring vital signs. These are all things that more than likely, usually we can delegate to unlicensed personnel or CNA. But when we go and assess the condition, the client is unstable. So we would not delegate those tasks to that unlicensed personnel. Delegation of patient care tasks and other healthcare workers is we got to just make sure that we are assessing it, assessing the condition, and then making sure that this is a task that this person can complete in that facility. Because there are variations in certain facilities that people can't do certain things. Okay, there's a small variation. And remember that we're responsible, the nurse is responsible for still supervising the care to ensure that it is competently delivered. Okay, let's go back to these rights here. So the right task, delegated tasks must conform to the established guidelines. The rights or the correct circumstances. Is this client stable versus unstable? The right person. Is this on the person's, the unlicensed personnel skills list? Is this have they been deemed competent? Have they been checked off and said they can complete this task? The right directions and communication. We want to ensure that we are giving the correct, clear explanation or instructions about what the task is. Turn and reposition this patient using two persons assistance on every even hour, 8 a.m., 10 a.m. So we want to make sure that we're giving correct instructions and directions and making sure that we're clear. Vital signs should be taken before lunch by 10 a.m., being clarify that time frame. And then the right supervision and evaluation, feedback, and we want to assess and improve the process, evaluate our client outcomes. This person needs to be turned and repositioned every hour? Do we need this person needs to be turned every hour and avoid the right side? Just evaluate and see if we need to change what the intervention that we're implementing. All right. So delegation is important, and it help nurses assistants also increase and improve their job skills. So if it's something that they can do and the circumstances are right, it's fine and stable, because we know that how they say if we don't complete a skill after so long, we kind of forget how to do it. So it will keep that unlicensed personnel up to date on their job tasks. Okay, let's see what else I want to talk about on delegation. Okay, let's talk about, so a CNA or unlicensed personnel, they can't delegate to another person. Only the nurse can delegate. A person cannot accept the task that's being delegated and being transferred to someone else. Okay. And if they're refusing whatever is delegated, have a conversation. Ask, what is really going on? Why are you refusing? We want to delegate only if it's allowed by the state Nurse Practice Act and that facility policies. Usually those two things are going to match up anyways, because facilities are not going to be asking you to do things that are not on your state Nurse Practice Act. We want to determine the stability of the client's condition, they're stable versus unstable. We want to provide specific, objective, clear-cut directions. The example that I gave, 10 a.m. using two persons assistants, being as specific as possible. We want to monitor the activities of the nursing assistants when they carry out the delegated duties, because you remember, we're not we're not relieved of that task just because we delegate. So we're going to monitor the activity. Sometimes it's a periodic check. Sometimes we have to be right there. It just depends on the situation. On completion of the delegated duty, we want to evaluate the safety and effectiveness of the duties delegated to the nursing assistant. Okay. So remember, we talked about the routine task, but if that client is unstable, then we would not delegate that routine task to the unlicensed personnel, even if it's something that is on their competency list. For example, mouth care, denture care, feeding them. We wouldn't delegate it because that client is unstable. So we would, of course, we would not delegate things that are not on the unlicensed personnel's scope of practice. For example, we should not be asking them to do sterile procedures, inserting a Foley catheter, administering medications. So we should not be asking them to do things like that. Let's see. Are there any questions? Because we've come to the end of our exam review here. Are there any questions about any concepts that we just mentioned? Make sure that you put your name and your professor's name and your campus in the chat. Something that came to mind here. Let me think about it. So most organizations, well, all organizations, they want to, for the most part, they want to remain open and they want to thrive. So what that means is that organization more than likely is want to grow. So they welcome input. Like we were talking about that theater inquiry in the event that the nurse, you're coming up with ideas about how to perform a procedure in a different way using less resources. Okay, so I do have a question. It says, so basically assertive is good and non-assertive is not so good. So yes, so assertive is the way you want to go. You don't want to be non-assertive and you don't want to be aggressive. Exactly. That's correct. Are there any other questions? Any other questions? So remember, we are life learners as healthcare providers. So we're all the time trying to evaluate and improve what we need to improve upon. As that nurse, you're going to have continued education units. And so those things that you've identified that you may need to improve upon and or need more knowledge about, that's where you want to get that more education. Remember, we want to make decisions based on the latest evidence. So we don't go back 5 years. So we're all the time learning what's the latest information. So in a workplace, think about how they evaluate competence. They're going to give you those evaluations most of the time. Sometimes, especially when you get first hired, they may do it 3 months, 6 months, and then thereafter every year. But that competence is a continuous thing where we're evaluating what we need to improve upon. And we all need improvement upon something. It's just a life learning thing. We talked about care coordination. It is fundamental improving quality of care while decreasing the inappropriate use, decreasing readmissions. We talked about that. I'm just going back through my notes. We've talked about. So just think it through. Look at the scenario. Identify what exactly the question is asking you. What is that main concept that they want you to address, and then answer the question that they're asking you. Because even though there's a scenario there, some of those things are just pieces of information, but the question is not about that information. I'm looking in the chat to make sure there are not any more questions. Okay. All right. So this recording will be provided here shortly. As soon as it downloads and uploads, we'll send it out to your to all the professors, but be sure to go back through all your classroom recordings. You have 2 weeks of classroom recordings. Plus, there are 4 of us. We have 4 recordings. So make sure you do that. Make sure you have your devices, your IDs, download that exam before coming to class, because that lessens the chance if something goes wrong, that you won't have that undue stress. Think about if you want that exam proctored, send an email that includes Dr. Brown, Dr. Mary Tenzer, because she's the course lead, whomever your professor is, your campus dean, and whoever that approved proctor is. Remember, you have to have that 72-hour notice. If you have accommodations, send that information to your professor. Take care. Happy learning.